As I'm not going to bore you with this slide, but essentially, I think we have already heard that transcatheter repair techniques currently are short of a good solution for every different pathology. And one of these, I think the major challenge is the closing pressure. Anchoring is difficult, of course, but the closing pressure is systolic, and hence there's going to be a constant displacement upwards, and that may cause multiple problems. One of the ways to address different pathologies as well as how the fixation happens is the Edwards Fortis device. So it has taken 7 years of different iterations to come to a point for the first generation Fortis device. It has got 3 parts. The central part is the functioning part, which is made of 3 bovine leaflets with a GLX technology. So it's a dry sealed valve. It comes pre-packed. And it looks like essentially a 29 sapien valve, which most of us have used in our practice today. It's self-expanding, so it's made from nitinol. More importantly, it has got 2 different additional parts. One is at the top, which is a flange, which sits on the base of the left atrium. And then it has got 2 pedals, which I'll show you in the next few slides, which help to anchor the device. So it's designed in such a way that one is it will sit very nicely and stay there. And the idea is that it will also reduce the PV leak. So these 2 pedals, which are exactly on the opposite side, essentially you will see it in the movie later, that they open and they go around the mitral in the A2 and P2 region, because that's the area which is without any chordae. And you have to place the pedals right at the AV groove junction, and that's pretty important. The delivery system is pretty intuitive, although it's large in size. It's at present 38 to 39 French. It's a transapical delivery system. And I must say that if we were not experienced in TAVI, and this delivery system was given to me 10 years ago, I would have really fainted. Today our experience in TAVI is there, so we can probably as surgeons, we can learn this slightly better. It's to a point to around 80% of the valve you can reposition it, not necessarily reuse the valve again, and to a point it is repositionable and again adjustable. So this is just an animation. It's a transapical procedure, slightly larger purse string than we are used to for transapical. The valves contained in the system, you essentially unsheath the pedals first and deflect them outside. There's a mechanism to do that with a knob, and then advance it in the A2 and P2 region to grab both the leaflets. At that point, you focus on the atrium and you release the top radar-like sheath at the base of the left atrium. Then essentially you're grabbing now the leaflets against the body of the main valve, and then you deliver the valve. And this is, again, there's a very famous surgeon from England, Ina, who said diagrams don't bleed. And actually it looks very nice on animation. So this is how it looks in animal implant. This is a chronic animal implant. Just to highlight, you can see the aortic valve and the mitral valve, that it can be done. And you can see how a surgeon's view will look like in a chronic animal implant. So I think the regulatory strategy, as Neil has highlighted, what we had to do was to go to MHRA or equivalent of MHRA in other countries, and then approach these patients as compassionate use in all these cases. The first case we did was on 18th of February in St. Thomas. As you can see, we are smiling, so obviously the patient had done well. It was a long procedure. And this is essentially the procedure. The procedure is echo-guided. I'm showing you a combination of fluoro and echo just so that you get a good impression. We place the wire. We make sure that we use a balloon catheter so that the chordae are not trapped. You put the delivery system, and you can appreciate that the size of the delivery system is much bigger than the transapical systems we use. And then unsheath the pedal, advance it to the AV groove. You can see it very nicely on 2D echo that this is in the A2P2 region, and the leaflet mobility pretty similar to a big mitra clip probably. And then you close the pedals on the leaflets and the body, as you can see it very nicely here. And then at that moment, you take a deep breath and then you release the valve, and the valve's released. And essentially, if you have caught the A2 and P2 properly, this is a really good procedure. And this is what we have learned. And we have already discussed that it's a tethered P2, it's going to be a challenge. And again, you can get some beautiful images. So totally 12 patients, and which I can disclose today. You can see that the first 3 patients from St. Thomas's, the age is 62, 57, and 65. So these are completely different patients than what we are used to doing TAVI. If I go back 8 years ago when we started TAVI, the age was 98, 98, and 98, or something like that. So these are very young patients. These are very sick patients. And these are the patients in which we had multiple problems. And you can see the procedure time, again, is variable. The first procedure was 84 minutes. Then it has come down to 36 minutes in our third case. Similar trend. When centers are doing more cases, it's just getting slightly easier. The acute recovery, the first patient was discharged after 15 days, was readmitted after 34 days, and then eventually died with heart failure in 76th day. Second patient, there was a technical problem. We did not capture the posterior leaflet completely. It was a partial capture, and the valve was displaced slightly up on one side on day 2. She was a renal transplant patient with a known history of active MRSA, and we lost her on the day 4. Day 3 patient, the third patient is most interesting. He's alive and doing well more than a year later. And then again, a similar trend in multiple other centers, but last 7 patients done in Canada have done extremely well. This is just to show you that the implant time, I wouldn't judge it too harshly at present. But as the centers are getting more experienced, there's a cross-fertilization of ideas. It's getting better and better. Now, I was talking to Mamta that as a surgeon, the only thing I looked on a mitral was during a case saying, oh, there's a bit of color, there's MR. I think we have to learn to educate ourselves. We have to learn ourselves to read echoes properly. And we have to slowly become cardiologists from that point of view. So the lessons we have learned is patient selection is crucial. Compassionate cases is very hard because these are the patients who are turned down for surgery, turned down for everything, and then you're screening them with a nearly 50 to 60% not suitable for this single size device which is there. So it's really bottom of the barrel. And these are extremely, so I think we have to change the tact and go to high risk rather than inoperable patients, and maybe we'll see better results. Imaging, again, as Neil has highlighted, extremely important. You spend a month of planning to do one case. And 3 important things are annulus, A2P2 distance, and more importantly, LVOT. LV geometry, we learned from second patient. She had a large aneurysm at the apex, which was calcified. So our puncture point was not ideal. And I think that's, again, very important that these sheets are very rigid sheets, and you only get single straight shot. You cannot maneuver them in any way. And again, John-Luc, I think your slide, the neocord, I think you have similar problem. If your puncture is not correct, you're going to be in a different place. So this is the diagram to show that if you are at angle of more than 45 or 15, 20 degrees, you're going to miss one of the leaflets. If given a choice today, I would rather capture posterior leaflet because the anterior leaflet is very large, and then you can capture it slightly lower and still survive. And other key important points, as again Neil and everybody has highlighted, that these are very, very important things. So this is the echo after 6 months. This patient, interestingly, we anticoagulated him for 6 months, and then he is just on aspirin. There is a lot of debate in the space now that because there is a lot of cloth on these devices, whether they need low-range anticoagulation lifelong. We are seeing some results from mitral valve in valve that some patients developed a very thin layer of thrombus on these valves because there's a lot of stent and cloth, and it disappears with anticoagulation. So I think the time will tell us the exact correct anticoagulation, but I'm sure in 88-year-old you probably are very skeptical about dual antiplatelet as well as anticoagulation. You land in another problem. So essentially the feasibility experience has now expanded. The US feasibility has started. We cannot disclose, of course, the results. UK, we are waiting for MHRA to approve, again, the feasibility study, as we can't do any compassionate cases at present. And once that starts, I'm sure with multiple devices and good centers participating, this space will only grow. Thank you.